This three-part series of lectures explores mental health issues in older people who present to the emergency department and pre-hospital care. The first lecture will focus on delirium, the second on dementia, and the third on depression, the 3 Ds of elderly care mental health. In this lecture, we will discuss the definition and epidemiology of delirium in older people, its clinical presentation, its diagnosis, and potential pitfalls. So, what is delirium? Pause the video and think about what your definition of delirium is. Well, delirium comes from the Latin word lira, meaning furrow, and delirare, meaning to jump out of the furrow while plowing. So, applying that to mental health and medical issues, delirium is a sudden, temporary change from the normal steady state that has a specific cause and that can be corrected. The key characteristics of delirium are an acute and fluctuating course, inattention, and either disorganized thinking or an altered level of consciousness, which can be depressed, drowsiness or lethargy, or exaggerated, such as hyperalertness and agitation. The confusion assessment method makes use of these key features. For the diagnosis of delirium, a patient must have both an acute onset or fluctuating course and inattention, and in addition to this, either disorganized thinking or an altered mental state. Again, I'd like you to just pause the video and try to think about some causes of delirium, particularly in older people. Okay, let's see what we've come up with. One of the major causes of delirium in older people is medication, particularly new medication or interactions between existing medication and new medication. Some medications that are particularly important in causing delirium are sedatives and hypnotics, anticholinergic drugs, which would include antiemetics, antihistamines and antipsychotic drugs, and stimulants. Infection is another very big cause of delirium in older people. The common sources of infection in older people include the respiratory system, the urine, and the skin and soft tissues. Diabetes and other medical causes are also common in older people. Another common and important cause of delirium is acute mental illness and alcohol and illicit drugs. And finally, intracranial pathology such as intracranial bleeds or strokes may also cause delirium in older people. However, it's important to understand that it's not the major cause. It's usually due to other things that we mentioned before. How do we assess the cause in a patient presenting with delirium? Well, as expected, we start by assessing the physical state of the patient and then thinking of the common causes. So think about environmental factors, hypothermia, trauma, carbon monoxide poisoning. When we say trauma, we're thinking about falls and head injuries. We need to monitor the vital signs, take a careful history, and examine the patient for any signs of these environmental factors. Metabolic and endocrine factors are very important. These include hypoglycemia, hypoxia, thyroid disease, renal and liver failure, and therefore we need to measure the patient's blood sugar, look at their vital signs, and do appropriate blood investigations. Not all of these investigations are relevant in every patient. We need to be specific according to our history and examination of the patient. Infection is another common cause of delirium, as we said before. Therefore, we need to seek the possibility of infection, particularly in the lung, urinary tract, skin and soft tissues. Our history and physical examination often reveals that there is infection, and once we are thinking of infection, we may need to proceed with blood, urine tests and radiological investigations as necessary. Neurological causes such as strokes, bleeds and tumors may be revealed through the history and physical examination and will lead us to decide whether we need a CT scan or not. But bear in mind, think about the metabolic and infective causes first. Identify those and treat them before you rush to a CT scan. Just some broad ideas about treating delirium. The first thing to say is that the biggest problem is recognizing it. We often don't recognize it because we're not really listening to our patient. We don't realize that they're confused, or assuming that the patient is always confused, underestimating the severity of the patient's confusion, or misunderstanding what we call hyperactive delirium. In other words, a quiet patient may still be delirious. Of course, the other thing about treating delirium is identifying and treating the underlying cause, such as infection, metabolic problems, drug-induced problems, and these are usually identified with a careful history and examination and judicious use of appropriate investigations. Remember that delirium is often multifactorial, so just because we identify one cause doesn't mean we should look for others. When treating delirium, we need to think about non-pharmacological factors that may be aggravating our delirium. In the emergency department, if the place is too hot or too cold, too dark or too brightly lit, too noisy, not private, this aggravates the patient who is confused. Restraints may be necessary, but remember, once you restrain a patient, their behavior tends to get worse and their confusion also tends to get worse. Pain is a common cause for aggravation of confusion, especially in older people. This should be considered, sought and treated. It's important to provide consistent and repeated reassurance both to the patient and their relatives regarding what's going on, and it's often useful to keep a relative or friend with the patient, as the patient who is confused responds better to somebody that they know. And look after the physiological needs: food, water, bowel and bladder function, and mobility. These are often causes of increasing agitation in the confused patient. If we do have to use pharmacological treatment, in older people, haloperidol is much preferred to benzodiazepines. We can give it orally, IM or IV, but in small incremental doses, often as small as 1 to 2 milligrams per shot until the patient settles down. Benzodiazepines cause respiratory and cardiovascular depression and should really be avoided in older people where possible. If you're going to give any of these drugs, think about drug interactions, so you need to know what other medication the patient is on and whether that may aggravate the side effects of either your sedative or the other medication. Bear in mind as well that all sedatives can cause confusion and all sedatives have cardiovascular and respiratory effects. Finally, what can we do to prevent or minimize confusion and delirium in older people attending the ED? Well, again, this goes back to our non-pharmacological factors in preventing delirium. So make sure these patients have an appropriate environment, communicate with them consistently and regularly, allow familiar faces, pay attention to their physiological needs, as well as pain control and mobility, and give them the necessary reassurance and attention that all patients should have. If you have any questions, you can post it on the WhatsApp group or the website, and we'll try to answer you. So in summary, delirium is a serious condition in the elderly which is often missed, and early diagnosis improves outcome. Our next lecture will be on dementia in the emergency department.